a single Medicaid system in this country. We've got 50 Medicaid systems all sort of stitched together, and they're not designed to help you move from one to the other. Consequence of not having a system that connects, that's designed to help people transition, and this is true of other kinds of insurance as well, is people remain locked where they are because they can't move, or they move in situations under duress. In California, we've seen problems with this under Title X, where people move because they're in a violent relationship, and they move to another, even within the state, they move to another part of the state, and they're now not where their coverage would take care of them. So this can be an inside state problem as well as across states. But if we were serious about maximizing people's medication compliance, if we were serious about maximizing health outcomes, even without getting to some kind of unified system, we could definitely come up with a system that would say there's an ombudsman, there's a way, there's something, there's one system you go through if you're going to move from one place to another. The other thing that happens is some states have, California in particular, have some free care systems for HIV. There are people who can't leave, even though it would make sense for them to be a caregiver to an elderly parent. Because of their HIV, their lower income, because of their health history, they are not the person out of their family network who's going to have a lot of other kinds of economic opportunities available. But they can't even go and fulfill this role because they can't leave where their coverage is. And I understood from a conversation last night, you're on the other end where people, so you have people moving here. The population showing up with HIV includes people who are moving here to take care of elderly parents, but there aren't necessarily the systems in place to provide them good care. I don't know what happens to them after their role as a caregiver goes away. But we're missing opportunities to support them. And if we don't come up with them, we will continue to lose people because of that. So what are some effective systemic and policy supports for keeping people on medication? I've raised a few suggestions going on, but I think we can also look to what's worked in other settings. And one of in other kinds of problems we've taken on, it's been a matter of adding taxes to different kinds of problems, adding bans and so on. We haven't had as much success in going in and adding interventions that make things facilitated, but we can imagine in some of the largest employers being able to engage them in discussions about what would work, because employers care a lot about the healthcare dollars they spend and what they get used for. What do they get in return? A statistic probably all of you have already heard is that Starbucks spends more money on health insurance than they do on coffee. And that figure is much, much higher when you talk about major employers like Verizon, where they have a very highly skilled workforce with high wages. They have very expensive, high-quality health insurance. They care a lot about days lost to illness. They care a lot about problems. In some of those cases, they actually have part of their HR devoted to be able to help people navigate these problems, and it feeds back into how do you solve things. This is a bigger issue when you're talking about big employers that employ people such that their wages are low enough that they tend to be on welfare at the same time. If you weren't on welfare, if you weren't already on Medicaid, in the face of, and you didn't already have insurance that was going to cover prescription medications, you are very likely to end up on public insurance fairly quickly in this process because of the huge price tag for the medications, or the number of hoops you have to go through to try to get on and stay on the programs that some of the pharmaceutical companies have to make a lower priced medication available. So there are a number of ways that we could step in this part, and that's what I want us to talk about in the discussion. In the meantime, I just wanted to give a few points that I had on potential policy responses. Part of it is we need to think beyond the individual as the outcome. There are models that are in place today, such as accountable care organizations in healthcare, and now accountable communities, where it's not just processes of care that get documented as we look at paying for care, but outcomes of care become important. If we had, as we do in an HMO model, especially a staff model HMO, if we have more global responsibility or more collected data, then it's easier to understand what's happening. I think one of the problems is simply that the numbers, the information that plans have currently is more what got spent than what went wrong. And health plans don't actually have a lot of information on what your outcomes were. They have information on what they paid for. And I use that kind of administrative data in a lot of kinds of work. The other piece is there's a huge opportunity out of engaging a range of behavioral scientists at other levels of decision making as we plan and make choices in what can make care less expensive and what can make care provide more optimal outcomes. Because if we had behavioral economists more involved in some of these decisions, it's a lot less likely that we would be going so far awry. If we took some of the expertise and understanding just in this room of behavioral pharmacology and said, how does that inform when you go in with a policy that's going to create these disruptions? What would you put in place to try to minimize the cost of that, to minimize the new incidences of HIV or the complications, which are very expensive, that are going to come out at fairly high rates? So we're really, what I really want you to come away with is a sense that what's possible for you to do individually and collectively in making a difference in health and healthcare, in making a difference in people's lives, goes far beyond what you usually think about in the classroom, what you usually think about in some of the kinds of controlled studies that we do, because there are many parts of motivating behavioral change that we might come at from a completely different perspective. And sometimes the part that you get that is most useful is what you bring from an understanding from a completely different field. Because one of the theories we talk about a lot in sociology is the strength of weak ties. If I want to learn something new, I don't want to go to the people who are most like me. The people who are most like me listen to the same news. That's more true than it ever was before. They read the same newspapers. They likely follow some of the same journals, or they study the exact same body of work that I study. It's when you go out there and you talk to people who are looking at it from another area, whether that's other academics in completely different disciplines, or people who are dealing with a problem out in the world from one of these other levels of decision making, or people who are living it. You may learn more from talking to the barista at Starbucks than from your colleagues about a brand new idea of what's possible. What are they facing and living and dealing with that could be different? And how can I take what I'm learning about motivating behavioral change and supporting sustained change that would be helpful in the world they live in? And that's what I want you to think about, how you can make a difference in the world. Thank you.